Okay. Sumit,
Yes, sir.
are you there? Yeah, you
Yeah,
start, no? You
yeah,
introduce everything
yeah.
first.
So, very good evening, everyone, and warm welcome to MOS, another episode of PG teaching program. And this month, on this occasion of Independence Day, we are having a second session of Retina, where we'll be discussing the very important cases of diabetic retinopathy and branch retinal vein occlusion. As you know, these are very frequently asked cases in every examination. We would like to thank our MOS and MOS office bearers for giving this huge platform to all the PGs all over Maharashtra to showcase their talent and present in front of such eminent faculty. I hand over to Dr. Santosh sir for his message to the PGs, and then Dr. Ashish will carry forward. Over to you, Santosh sir.
Thank you, Dr. Sumit. Respected seniors, teachers, and my dear colleagues, PG friends, very good evening to everyone and wish you happy Independence Day as well. On behalf of MOS, I welcome you all to this distinguished webinar, specially curated for our PGs and resident doctors. This webinar would throw light on the very common retinal conditions, that is diabetic retinopathy and branch retinal vein occlusion. I am sure our PGs would be benefited from today's webinar. I wholeheartedly thank Dr. Vignesh, Dr. Manoj, Dr. Rakesh sir, Dr. Rohit for sparing their invaluable time for this webinar. I am also grateful to our moderator, Dr. Ashish Ahuja, and our presenters, Dr. Deep Lata and Dr. Aishi. I would not perform my duty if I don't mention the name of Dr. Sumit Lahane, who has been instrumental in running these PG training webinars from the very beginning of this year. I am indebted to Dr. Vardhaman, Aditi, Atul, Mandar, and whole team of MOS for the incessant support for this project. On behalf of MOS, I strongly condemn the heinous crime that happened in RG Medical College Hospital recently. As a society, we are going to raise our voice against this and prevailing situation in government medical college and hospital as well. I appeal all PGs to be careful, alert, and take care of yourselves. We all are with you. Also, please do attend these webinars to update your knowledge and skill in order to perform better and better in your exams. My today's quote is self confidence is a superpower. Once you start to believe in yourself, magic start happening. So be confident, work hard and conquer the world. Best of luck to you all and thanks for your patient listening. Thank you everyone. Over to Dr. Sumit.
Yes, thank you so much, sir, for your all inspiring talk and always the inspiring quote. And I will hand it over to our moderator today, Dr. Ashish Ahuja, who will be introducing the faculty, and then we'll start the presentation with
Yeah,
Dr. Aishi. Oh,
before
yes,
that,
sir. Yes,
I
sir.
welcome Dr. Atul, our honorary secretary, MOS. Atul, you want to say anything addition?
Right, it's very good. Today's topic is not only pertinent to the member, to the students, but it's in day-to-day practice. We come to across the same cases, and I like that you condemned the barbaric killing of the girl because we should stand beside her, and so MOS is always MOS stands for that. Such a cruel incident should also always be there. Thank you. So let us begin with the program. Over to Dr. Ashish Ahuja.
Thank you, sir. And it is my pleasure to introduce the eminent panelists and mentors which we have for the session today. First, I would like to introduce Dr. T.P. Vignesh. He has been my teacher and mentor as well. He is a prolific vitreoretina consultant and he's completed his MBBS from the University in Bangalore and currently working in Arvind Eye Hospital, Madurai. And he has several publications to his name and very regularly features on the cover pages of our international journals as well. Next, I would like to welcome Dr. Manoj sir. He is a Vitreoretina consultant practicing in Aurangabad. He is the director of Saswade Eye Clinic, and he does a lot of philanthropy work. And he's been conducting camps regularly across 12 districts in Maharashtra over the past 12 years. And next, it's my pleasure to introduce my good friend, Dr. Rohit Modi. He is an excellent vitreoretina surgeon and also an innovator as well. He has over a decade-long experience and in performing complex vitreoretina surgeries. And I'm glad and also looking forward to learning from all the mentors. We will start with the first case presentation of the day. That will be by Dr. Aishi Mitra. She is a postgraduate in GMC Hospital from Mumbai, and she'll be presenting a case of branch retinal vein occlusion. Dr. Aishi, you may share your screen.
A very good evening to everyone. This is Dr. Aishi Mitra, second year junior resident from Grand Government Medical College. I will be presenting a case on branch retinal vein occlusion today. But before beginning with the presentation, I would like to thank MOS for giving me such an opportunity to present a case on this platform. Also, I would like to wish all of the teachers and faculties and doctors present a very happy Independence Day. Now, let's begin with the presentation. A 45-year-old male presented to our OPD with complaints of diminution of vision in right eye since last 2 weeks. Patient was apparently well 2 weeks ago. Then he developed sudden diminution of vision in the right eye, which was sudden in onset, painless, and progressive in nature. There were no history of flashes or floaters, no history of any ocular surgery or trauma. Patient is a known case of hypertension on treatment since the last 2 years. He has a history of smoking since last 5 years, smokes around 4 to 5 cigarettes per day. On general examination, the patient was well oriented to time, place, and person. His BP was found to be 150 by 90 millimeter of mercury. On systemic examination, all were found to be within normal limit. On torchlight examination, his head posture, forehead, facial symmetry, ocular adnexa, extraocular movements, all were found to be within normal limit. Best corrected visual acuity in right eye was found to be 6 by 36 on distance linear chart, and in left eye it was found to be 6 by 6. Lids, conjunctiva, cornea, all were found to be normal. Anterior chamber was normal in depth, iris was non-pigmented, pupil was normal in size reacting to light, lens was clear. On 90D slit lamp biomicroscopy, the foveal reflex was absent and an elevation was seen at the macula. In left eye, all the anterior segment findings were found to be within normal limit. Intraocular pressure was checked on non-contact tonometer, which was found to be 16 millimeter of mercury in right eye and 18 millimeter of mercury in left eye. On fundoscopy, on direct ophthalmoscopy, in both eyes, red glow was seen. In left eye, on indirect ophthalmoscopy, the media appeared to be clear. Optic disc was normal in size, shape, color. Cup to disc ratio was found to be 0.3 to 0.4 in both vertical and horizontal. Neuroretinal rim was healthy with arteriolar attenuation seen in the blood vessels with a arteriovenous ratio of 1:3. Macula was found to be elevated and with multiple flame-shaped hemorrhages were seen mainly in the superotemporal quadrant. Indirect ophthalmoscopy done in left eye revealed a clear media with a normal optic disc which was normal in shape, size, color. Cup to disc ratio was 0.3 to 0.4 with a healthy neuroretinal rim. Blood vessels showed arteriolar attenuation with an arteriovenous ratio of 1:3. Macula appeared normal with tessellated background. My provisional diagnosis is superotemporal branch retinal vein occlusion with macular edema in the right eye and grade 1 hypertensive retinopathy in the left eye. Thank you.
Thank you, Dr. Aishi, for the nice and lucid case presentation. Can you tell me how do you classify stages of hypertensive retinopathy?
Yes, sir, there are 4 stages. In grade 1, there will be generalized arteriolar attenuation with broadening of arteriolar light reflex. In grade 2, there will be a severe generalized arteriolar constriction with deflection of veins at the AV crossings, which is also known as Salus sign. In grade 3, there will be copper wiring of arterioles with flame-shaped hemorrhages, cotton wool spots, hard exudates will also be seen. There will be venous banking and venous tapering at the AV junctions. And in grade 4, all of the findings found in grade 3, along with there will be a silver wiring of arterioles and papilledema.
Yes, stage 4 is along with papilledema, disc edema. Acha, I request you to stop screen sharing, please.
Okay, sir. Just a minute.
Next, could you tell us again, BRVO is an important even clinical case during practicals as well as a question. Could you tell us the mechanism of action of pan-retinal photocoagulation, the sectoral PRP laser, which is done in a case of BRVO?
So the laser light which falls on the retina is absorbed by the melanin which is present in the retinal pigment epithelium, which results into destruction of the photoreceptor, and there is a reduction in the oxygenation of the inner retinal layers. Which thereby, as there is reduction in the oxygenation, there is O2 flux which occurs from the choroid, which goes into the inner retina and which improves the oxygenation in the inner retina, thereby decreasing the VEGF, which leads to reduced vascular permeability and vascular leakage, thereby leading to reduced neovascularization and macular edema.
Yes, correct. Would the panelist also want to ask something to the presenting?
What investigation would you like to do in cases of BRVO?
Sir, at first, we will try to rule out any systemic causes. If the patient has just like risk factors contributing to BRVO could be hypertension, so and then diabetes mellitus, hyperlipidemia. So I will do a routine workup which will comprise of CBC, ESR, CRP, fasting blood pressure, fasting blood sugar, postprandial blood sugar, HbA1c, then homocystinuria, and in cases if we are suspecting any blood dyscrasias or coagulopathies, then we should rule out those also, screen for thrombophilia.
See, Dr. Aishi, very important when investigation is asked, no, this pertains for any disease, always classify it into ocular and systemic investigation. So systematically, you divide it. In ocular investigations, then you can enumerate,
okay,
and
sir.
systemically, you can tell separately.
Okay, sir. In systemic evaluation, we will do a routine blood checkup, which will comprises of all the investigations, just like I mentioned, CBC, ESR, CRP, hemoglobin, fasting PP, HbA1c, ESR, homocystinuria, and in ocular examination, I would like to proceed with OCT macula, OCT disc, fundus photo, and fundus fluorescent angiography.
What will you get the information on doing the angiography?
Sir, in angiography, we will inject the dye and we will check for non-perfusion capillary areas.
Okay. At what time you will like to do the angiography? immediately the patient comes to you or after a few days?
Sir, after a few days.
Why?
Sir, after doing all the routine checkups, then only we do fundus fluorescent angiography.
If there is a blood in the retina, will it be possible to find out the findings on angiography, or it will cause the blockage of the fluorescence?
Sir, it will cause the blockage.
So,
So in this
yes,
this case, like this was just acute, right? So that means a lot of hemorrhages will be there. So angiography may not be helpful in here because of the hemorrhages will block. So you cannot know whether there is ischemia or not in such a case when you are doing it acute the first time present. So you know this in this case, what is the risk factor in this case for the development of BRVO?
So smoking, then smoking.
Yes, smoking, and then
The patient was hypertensive with a high BP, not controlled on medications.
Not uncontrolled on medications.
Uncontrolled medication.
So what was the medication patient was taking?
Sir, he was taking antihypertensive, beta blockers.
Yeah, no. What is the medicine? What is the dosage? How long he was taking? So the detailed history on hypertension as well as the medications he is using for hypertension is also important. So you should have asked for all the details about the medication he's using, how long he's using, whether he's regular with the medications, what kind of maybe even work-related or any stress. That's also very important. And also, what about his weight and height? Was he obese or normal build or?
He was moderately built.
Yeah, so that is also very important because people with obesity or overweight have a higher chance of developing BRVO, especially in the younger age group near the around 20 to 30. Having higher BMI have a higher risk of developing BRVO later in life. So that is another factor you should have checked for weight, height, as well as the BMI has to be calculated. So as you said, we can just do a fundus photo to record. Also to educate the patient, we need to take a fundus photo, show what has happened, because showing the hemorrhages as well as OCT, you can educate, show the macular edema. So what is the pathogenesis of BRVO? How, why it develops in hypertension? What happens?
Sir, there is a long-standing BP, blood pressure is raised in the patient. So there is thickening of the retinal arterial walls. And at the AV junctions, the retinal vein and the artery, they share a common adventitial sheet. So when the thickened retinal arterial wall compresses on the vein, so there is turbulent abnormal blood flow in the vein, which leads to hypoxia and releases VEGFs, which leads to increase vascular permeability and leakage, resulting into macular edema.
Good. So once you find out, so you are going to now proceed with the investigations like OCT, right?
Yes, sir.
So what would you expect in OCT in a case of branch retinal vein occlusion?
So there will be a distorted foveal or enlarged foveal contour of and there will be cystoid, intraretinal cystoid spaces will be seen, which will tell us that it's a cystoid macular edema.
Yes. So will all vein occlusion lead to cystoid macular edema?
No, sir.
So have you seen vein occlusion acute without cystoid macular edema? Will a patient present to us, the patient does not have cystoid macular edema to us because there will be no vision disturbance. Such a case. Will a patient present just with some any visual disturbance without macular edema? Is it possible?
I think possible, but I don't have any idea about it.
Yes, it's possible. So yeah, you can have a minimal vision disturbance even without CME being developed. Okay, so what will be your first? So can we go to the treatment aspect as well, or just it's an investigation as of now?
Sir, we will have a panel discussion.
Okay, right.
So, Dr. Aishi, next question for you is, how will you differentiate between non-ischemic and ischemic form of retinal vein occlusion?
Sir, in the ischemic form, there will be higher chances of neovascularization. And in fundus fluorescent angiography, there will be more than 5 disc diameter areas of non-perfusion will be seen. And in on fundoscopy there will be less hemorrhages and less cotton wool spots. If we are comparing it to the non-ischemic one, there will be there will be extensive exudates and hemorrhages in the non-ischemic one, with there will be low risk of neovascularization in the non-ischemic one. And there will be good perfusion on fundus fluorescent angiography in non-ischemic.
And if you're seeing a macular ischemia, how does that appear on fundus fluorescent angiography and visual acuity?
Sir, it will appear as a foveal avascular zone.
Yeah, what happens to the foveal avascular zone?
Sir, it won't take the stain in. There will be low perfusion.
Yes, so just yes, he is right, but just elaborate properly. Your second year student. So,
yeah, good. There is a widening and enlargement of the foveal avascular zone, and it will become irregular, and also the visual acuity will be poorer for these patients. Even after multiple anti-VEGF injections, the vision will not improve. So that is one key or a sign which you can notice. Next, could you tell me the different anatomical types of retinal vein occlusion?
Yes, sir. There are majorly 3 types: central retinal vein occlusion, branch retinal vein occlusion, and hemiretinal vein occlusion. In central retinal vein occlusion, since there is occlusion of the central retinal vein, so all the 4 quadrants are involved. In the branched, there is segmental or sectoral involvement, since a branch of the central retinal vein is involved. Then BRVO is again can be classified into major BRVO and macular BRVO. In major, there is occlusion of a single venule that drains a segment, and in macular, the occluded venule lies within the macula. And in hemiretinal venous occlusion, there is either the upper or the lower part of the retina is affected.
Okay, good. Next, I would like to ask the panel to share some of their experiences and pearls. So, what do we consider as the end point of treatment in patients with branch retinal vein occlusions? Could you please share, sir? Dr. Manoj?
see, the thing is that why we investigate. Systemic investigations and ocular investigations will give you the prognosis or the limit of the treatment. Whether this is an inflammatory type of BRVO, if it is associated with homocystinuria, then obviously these most of the time they are self-resolving, or it will require systemic therapy. Second most important thing is that the why to treat. There are 2 components of treatment. One is the macular edema and second is the neovascular complications. Macular edema is because of the oozing, as you have already told that there is an increased permeability. And permeability is not a lifetime most of the time. Either it stops, sclerose the vessels, and over a period of time, maybe after 1 year, 2 years, you may not get the cystoid macular edema or anything, but there will be a complete ischemic things. And other things are there, like a neovascularization because of the avascular zones or ischemic zones, which demands the oxygen, as you are rightly told. And because of that, there will be a liberation of the VEGF and neovascularization. So the treatment depends upon in the 2 forms, for the macular edema and for the neovascularization. It is a sectoral, very easy to treat the neovascularization. If you do good PRP in that sectoral or sectoral PRP, you will get rid of the neovascularization permanently, unless and until it is a very huge vascular zone, more than 10 inch diameter, and involves the neovascularization of the disc. Then you may do the complete PRP. Otherwise, sectoral PRP, good sectoral PRP will manage the neovascular component, while the macular edema component has 2 lines of treatment. First, you have to reduce the thickness by giving the anti-VEGFs. Once the thickness is reduced, then you can think of doing the grid laser or focal laser or micropulse lasers once, twice, thrice, and that will give you the good result. And if again there is a rebound edema, that rebound edema will give you the two things. Either there is a no systemic good control, persistent hyperlipidemia, persistent derangements of the blood pressure or smoking and all those elevating factors, or you may require more lasers and more injections in that situations. So there is a definite end to this treatment as far as the BRVO is concerned. If it is a CRVO case, you may not know when you are going to stop. It will keep on coming, going. That means rebound edema is the rule in non-ischemic CRVOs. While the BRVOs, it's definitely with good control, systemic control and good local treatment, you will find a good result in these cases.
Thank you, sir.
You can add to this one.
Next, Dr. Rohit, I would like to ask, could you share some counseling tips which we can use for counseling patients with BRVO?
Thanks, Ashish. So my take would be that I explain the patient that you will require anti-VEGF injections, and I counsel them about the type of injections which are going to be required, and also SOS if, like Manoj sir has said, patient may require sectoral laser. Along with the ocular treatment, the importance has to also be given on the systemic risk factors which are associated. Quite a few patients, which I have seen in my practice, have been undiagnosed hypertension, or they are hypertensives on treatment, but they are not well controlled. So those aspects have to be also be looked into.
Dr. Vignesh, could you share how would be our approach if we are seeing a patient with a bilateral vein occlusion?
Yeah, so bilateral vein occlusions, we have to investigate like systemically, because bilateral will be like most commonly because of systemic issues. So especially like when we have a bilateral CRVO, and we also have you have to divide the young and the old. So the old, like we have mostly the diabetes, hypertension, cardiac, hyperlipidemia. Those will be the causes for bilateral vein occlusions. And also when they're young, we have to see for the coagulation profile. So especially like protein C, protein S deficiency, and also hypercoagulable states, and also like history of smoking as well as homocystinemia. So these are the important things we have to investigate, because without this controlling of these or eliminating these risk factors, we are not going to treat. We are not going to get a full benefit of treatment by giving anti-VEGFs or anti-VEGF or steroid or lasers. So until we investigate thoroughly for bilateral cases and also find out the cause and treat the root cause along with the treatment of our systemic factors with our ocular treatment, then we will have a full success. So just I want to share one case of BRVO. So when the patient is saying middle age, 40-year-old female came to me for a sudden drop in vision of 660, and her pressure was 200, and the macular edema was around 500. So the first thing I did was I did a thorough systemic evaluation, like look for blood urea, serum creatinine, urine microalbumin, albuminuria, and also sent for a physician evaluation to rule out any cardiac abnormality in the patient by doing a ECG echo, and everything was done. But the only risk factor in the case was blood pressure. So despite having a vision of 6/60 and 500 microns, my first approach in that case was systemic control. So once the BP was brought into control with systemic medications, you will not believe in 15 days, the vision became 6/6 and the edema was nil. So it became 200, normal thickness. So why I want to highlight this case for the PGs is like the first thing we are going to do, if we are not going to eliminate the root cause and we are going to only inject, it's not going to help. So with just an observation along with a good hypertensive control by referring to a proper physician with a proper workup and eliminating the hypertension resulted in macular edema resolution fully. And also I followed up the patient even after 6 months, there was no recurrence of macular edema. So there's really surprised to see like whether just the systemic control is alone enough when we are knowing the cause of that hypertension is the cause for that PRVO, just controlling it will be enough. So same way, if the patient is having also nephropathy or urea and creatinine are elevated or serum homocysteine is elevated or patient is smoking. So when you're going to remove the risk factor, your half of the treatment or even nearly a full treatment like this will be done. So you'll be like very, easily you can treat such patients. So first thing is a thorough systemic evaluation and thorough systemic control is very important, especially in bilateral cases. Thank you.
Thank you, sir, for the valuable inputs. Now we move on to the next case that will be presented by Dr. Deeplata. She'll be presenting a case on diabetic retinopathy. You may please share your screen. Dr. Deeplata, your audio is not, you're not audible.
Deeplata, please unmute yourself.
Dr. Deeplata, start presenting, please.
Yes, sir.
Make it full screen and start presenting. To the glass-like icon on the right lower corner of your laptop. It will make it full screen like you had done it in the beginning. Or it's okay, you can present like that also if you're not able to do the full screen. Any problem, Dr. Deeplata, you can tell us.
No, sir.
So please go ahead.
Good evening to all. Myself, Dr. Deeplata. I am presenting the case of diabetic retinopathy.
The first slide you'll have to change directly from the arrow which is there on the Zoom screen. After that, you can change with your keyboard buttons. So go to the full screen like you had gone.
Yes, sir.
There will be arrow on the right lower corner, left lower corner of your Zoom. Press that so you can go ahead.
Right.
Start presenting, please. It's okay. Even if you don't make full screen. Dr. Deeplata, please start
Yes, sir.
presenting.
Yes, sir.
Or maybe Rahul can do it from his end. Is it possible? Well, it's okay even if you present like this. Nothing else.
Okay, sir. Good evening to all. Myself, Dr. Deeplata, resident, junior resident 2 from RGMC, Hilwa Thane. I am presenting the case of diabetic retinopathy. The chief complaint of my patient, a 65-year-old female resident of Kalwa Thane, a housewife, came to the ophthalmology OPD with the chief complaints of diminution of vision in the both eye since 7 months.
History of presenting illness. Patient was apparently all right 7 months back when she developed diminution of vision in both eye, which was painless, gradual, and progressive in nature. History of spectacle use present since 4 years, and no history of trauma and floaters. Past history. History of diabetes mellitus since 6 years, for which she was on oral medication. There was no history of hypertension, tuberculosis, asthma, drug allergy, and previous ocular surgery and other ocular treatment. Personal history, normal appetite, and no history of the other substance use. Family history not significant. General physical examination. She is moderately built, nourished, conscious, cooperative, and oriented to time, place, and person. Blood pressure 136 by 90 millimeter of mercury, and breast systemic examination within normal limit. Head posture was normal and face bilateral symmetrical. Now the ocular examination. Uh, in the right eye, uncorrected visual acuity 6 by 60, and best corrected the uncorrected visual acuity in the right eye was 6 by 60, and in left eye 6 by 36. The best corrected visual acuity 6 by 18 partial with refractive error plus 2.5 diopter sphere and minus 2 at 180 degree cylinder. In left eye, best corrected visual acuity was 6 by 24 with minus 4 sphere and minus 1.5 at 65 degree cylinder. Intraocular pressure with the Goldman applanation tonometry at 11 a.m. In right eye, 10 millimeter of mercury and 12 millimeter of mercury in left eye. Now the anterior segment in both the eye was normal, except the lens. Nuclear sclerosis grade 2 was present. Now the fundus examination in right eye done with the slit lamp biomicroscopy with plus 90 diopter lens and indirect ophthalmoscopy with plus 20 diopter lens. The glow was red. Seen was with the distant direct ophthalmoscopy. Media was hazy due to cataract. Optic disc, vertically oval disc, and horizontal oval cup with cup disc ratio 0.3. Well-defined disc margin and healthy neuroretinal rim. Blood vessels are arise from the center of disc and dichotomously branched with AV ratio 2:3. Background discrete, well-defined superficial red lesion along the along the along the capillaries suggestive of microaneurysm. 2 to 3 deep pinhead-shaped red lesion not continuous with the vessels, suggestive of dot blot hemorrhages seen in inferior quadrant. Multiple yellow waxy lesion with distinct margins arranged in the clumps along the superior and inferior arcade, suggestive of hard exudate. The white fluffy lesions with indistinct margin, suggestive of cotton wool spot near the superinasal arcade. Macula, foveal reflex was absent. Yellowish waxy lesion with distinct margin in clumps, suggestive of hard exudate around the fovea. This is the fundus diagram of the right eye. And this is the fundus photo of right eye. Now the fundus examination of left eye. The glow was red by the distant direct ophthalmoscope and media was hazy due to cataract. Optic disc, vertically oval disc and horizontal oval cup with cup disc ratio 0.4 and well-defined disc margin with healthy neuroretinal rim. Blood vessels arise from the center of disc and dichotomously branch with AV ratio 2:3. Background discrete, well-defined superficial red lesion along the capillary, suggestive of microaneurysm, and multiple scattered deep pinhead-shaped red lesions not continuous with vessels, suggestive of dot blot hemorrhages. Multiple yellowish waxy lesion with distinct margins, suggestive of hard exudate along the superior and the inferior arcade. Macula, foveal reflex absent. Multiple yellow waxy lesion with distinct margin, suggestive of hard exudate present around the fovea. This is the fundus photo of left eye, fundus diagram of left eye, and this is the fundus photo of left eye. Now, probable diagnosis. My patient with both eye, grade 2 nuclear sclerosis cataract with moderate non-proliferative diabetic retinopathy with clinically significant macular edema.
Thank you, Dr. Deeplata, for your case, sharing your case. Could you tell me what are cotton wool spots and in which layer are they present?
Cotton wool spots are they are the nerve fiber layer infected nerve fiber layers, and due to the interruption of the axonal flow caused by the ischemia, and they are present in the nerve fiber layers because they are the infected nerve fiber layers.
Okay, very good. Also, then, can you share what is the criteria to diagnose a patient with moderate stage of non-proliferative diabetic retinopathy, as in your case?
So, according to the early treatment diabetic retinopathy study, ETDRs, we classify the diabetic retinopathy into the proliferative and non-proliferative. So, in a non-proliferative diabetic retinopathy, the moderate NPDR is if the severe hemorrhage is present in C3 quadrant and the venous bleeding in one quadrant and with very mild irma is present. This is the moderate NPDR.
Okay, good. Could you tell me what are the different types of macular edema which we come across in a case of diabetic retinopathy?
Uh, these
Or
are the diabetic macular edema is like focal, diffuse, ischemic, and mixed type. And according to the OCT classification, like non-central and central macular edema, classify the macular edema.
okay, good. Could you tell me four different molecules of anti-VEGF injections that are available?
So, like we classify the anti-VEGF into a different type according to their mechanism. So we have example like bevacizumab and ranibizumab, aflibercept and pegatinic, older anti-VEGF, and newer like sorafenib and sunitinib, and newer one is the brolucizumab. So,
Okay, good. Could you tell me what is an IRMA and how do you differentiate it from a neovascularization?
IRMA is an intraretinal microvascular abnormality, and these are the fronts between the arterioles and the venules, and they are differentiated from the new vessels because they are intraretinal and the new vessels are like superficial and um, like they are not leaky, but the new vessels are the very fragile and they are leaky, and they are never cross the major blood vessel, like new vessels are crossing the major blood vessels.
Okay. Now I request you to stop your screen sharing. We will have a panel discussion now. Dr. Manoj, would you like to add your comments on the case?
Yes, she has presented very nicely. This is a case of moderate NPDR. How you classify the PDR, diabetic retinopathy as such?
So like early treatment diabetic retinopathy study according to this, we classify the diabetic retinopathy into the NPDR and PDR. In the NPDR, we classify divided as like very mild NPDR. Only the microaneurysm are present in the very mild NPDR. In mild NPDR, the like exudates hemorrhage with microaneurysm. And in moderate NPDR, like less than the severe NPDR, like in severe NPDR, 4 to 1 rule is there. For like severe hemorrhage is more than 20 present in all 4 quadrants, and two is venous bleeding is present in 2 quadrants, and one is IRMA, intraretinal microvascular abnormality, are present in 1 quadrant. If any one of these present is called moderate NPDR, if more than two of these present is called severe NPDR. And it's like proliferative diabetic retinopathy, like high risk and advanced. High risk, like if neovascularization of disc more than one-third disc area present, and NVD with vitreous hemorrhage, or NVE, like neovascularization of elsewhere more than half disc area with VH, is called high risk PDR. Or like in advanced PDR, vitreous, if any hemorrhage is like retinal hemorrhage, vitreous hemorrhage, or fractional RD, or rubiosis iritis, or all are three are involved in the advanced PDR.
Okay. What was the cause of low vision in this case?
Like it's a macular edema, clinically significant macular edema.
How you diagnose it?
On the basis of clinical examination, we classify. These are the three criteria of the clinically significant macular edema. If the retinal thickening present within the 500 micron from the center of the fovea, or any hard exudate with the retinal thickening present within the 500 micron from the center of the fovea, or if any retinal thickening more than 1500 micron uh, present within the 1500 micron is called the CSME.
All these were present in your case?
Yes, sir.
Yes. Now, how will you proceed?
So first, I will do basic routine systemic investigations,
Good.
and then the ocular investigations. Like first, I will do the blood sugar levels, HbA1c, and BP monitoring, and some lipid profile, and the kidney function test. So, and in ocular examination,
Ocular, what will you do?
sir, in my case,
Yeah, in your case only we are discussing.
sir, sir, I will give patient intravitreal anti-VEGF, sir.
You will go for the anti-VEGF. Before that, you will not like to do any investigations, local investigations, ocular.
OCT or FFA, sir, fundus fluorescence angiography, and optical coherence tomography.
Okay. Good. It is available at your place, or you will refer this to the for the investigation.
Sir, I will refer. We have only OCT facility, not
Okay.
fundus fluorescence angiography.
Is it how OCT is important before treatment?
Sir,
What is the role of OCT in
sir, to diagnose the
maculopathy?
हाँ,
One is
macular, sir,
yes, correct. You proceed. You are talking very well. One is diagnostic. You diagnose macular edema on the basis of OCT, correct? You are
OCT.
center involving, non-center involving. You know it. Then any other things you will want to know from the OCT, or they take the help of OCT.
Sir, for the prognosis or the response of the therapy, we will do the OCT.
Good. Keep on talking. Yes, you are talking. You are studied very well.
Or for the signs of chronicity or the signs of atrophy.
Very good. Very good.
We'll move on to the next question. Vignesh sir, could you share insights on when would we use steroid injections in a case of diabetic retinopathy?
Yeah. So we had first initially lasers as focal laser or grid laser as gold standard for treating diabetic macular edema. But then once we had anti-VEGFs, so the anti-VEGFs resulted in improvement in vision, which was not there with the focal laser photocoagulation. The improvement of vision happened with the usage of anti-VEGFs. So anti-VEGFs have become the gold standard for treating diabetic macular edema. So, but there are conditions like where we cannot use anti-VEGF or where anti-VEGF response is not there. So I will just enumerate the causes like why anti-VEGF cannot be used. Like in cases of recent myocardial infarction, in case of recent stroke, in cases of chronic renal failure, and or even acute renal failure, this is nephropathy cases. These cases, like we cannot give anti-VEGF for the risk of development of thromboembolic conditions. So in these cases, I would prefer giving a steroid. That is one point from the systemically. So this is very important, like for the PGs to know. So recent MI, recent stroke, and nephropathy. These are contraindications for giving anti-VEGF injections. These are very important thing. And also systemic hypertension, uncontrolled systemic hypertension, where like it's better to avoid anti-VEGFs or to give anti-VEGFs only after control of systemic hypertension. So, but if it is not getting controlled, adequately controlled, I would better prefer steroids from the systemic point of view, ocular steroids intravitreal steroid rather than going for anti-VEGF. Well, when you are considering the ocular factors, especially in pseudophakic eyes, older patients like who have undergone already cataract surgery and no history of any steroid response previously with any kind of topical steroids, and also no history of any ocular and no signs of any glaucoma in those cases, we can definitely go even as a first line. You can go with the intravitreal steroids. That is one of the ocular things we have to consider. And another thing, the last thing is when we are not having adequate response with anti-VEGF therapy. First thing is like after 3 repeated injections, monthly injections of anti-VEGF, if there is no adequate response, we can switch over to another anti-VEGF. But even then, you are not having a response. It's better to switch over to steroids. These are the conditions like where I use steroids. But as a routine, I would recommend as a first line in case of pseudophakic patients, and also when you have the OCT factors, I want to highlight certain things like chronic edemas, especially large cyst, SRF, large amount of SRF, large cyst, lot of hard X-rays, and also a lot of hyperreflective foci. These are the biomarkers which we are seeing in the OCT. Not just the monitoring of the Deepalata just not just for the monitoring of the DME, but also for the biomarkers which are there in the OCT. So OCT is very important. So OCT factors are presence of lot of hard X-rays, lot of hyperreflective foci, large serous macular detachment, as well as chronic edema, like we have a large cyst. I would prefer steroids rather than anti-VEGF. It doesn't mean that the anti-VEGF doesn't work in those cases, but it is anti-VEGF can work, but steroids will have better efficacy than anti-VEGF in treating cases which are showing chronicity. That is a very important thing. So those patients I give steroids. Another important thing is when you have a juxtafoveal large hard X-rayed clump. What happens is when we give anti-VEGF, sometimes this rapid reduction in edema, this hard X-rays can migrate to the fovea, causing loss of vision. So already the patient has a decreased vision. On the top of it, when you are going to give in a case with a dense hard X-rays, not at the fovea but juxtafovea, even at the fovea means it is like bad vision with there even from the beginning. But if it is a juxtafoveal, but you have some better vision, but if it is causing rapid resolution reduction in the edema, these hard X-rays can migrate into the fovea, causing decrease in vision. So that cases, like I would prefer steroids because steroids not only will decrease the edema, but also cause a reduction in the hard X-rays, which we have seen in a lot of times. So in dense hard X-rays, juxtafoveal or parafoveal, better to prefer steroids.
Thank you, sir. Next question I would like to ask Dr. Rohit. Could you share insights on the role of diet and nutrition in managing patients with diabetic retinopathy?
So, thank you, Ashish, for this question. There is a big role to play for us when we are speaking to our diabetic retinopathy patients, especially about the lifestyle change, because patients with DME have a much higher risk of having stroke and myocardial infarction as compared to patients of diabetic retinopathy without DME. So once we see a patient with DME, we know that the patient has a higher risk of systemic complications because of diabetes. So there are a lot of data to show that whole food plant-based diet has shown to partially reverse diabetes mellitus and also help in better control of the diabetic macular edema. So encouraging them to shift to whole foods and also encouraging them to develop a exercise plan simultaneously can help us reduce the amount of treatment which is going to be required subsequently and reduce the risk of future systemic complications.
Thank you, Dr. Rohit, for sharing your insights. Next, I would like to present a case scenario just for discussion. So, these are very important topics, and diabetic retinopathy is, as we know, one of the leading causes of blindness and also a very important exam question. So the examiners could, present different scenarios with fundus pictures, like in this. So a 51-year-old male with a vision of BCVA of 6 by 24 in the right eye and 6 by 36 in the left eye, with diabetes since 14 years. So any of the panelists can take it up. How should the postgraduates approach describing the case and managing this patient?
The post-graduation students should present one by one, right? Rightly they were presenting the right eye, the media is clear, what is the state of the disc cup ratio, and whether there is a presence of NVD in case of PDR, along with the ratios also. What is the arterial thinning is there, atherosclerotic changes are there, and the blood vessels. Apart from the blood vessel, the hemorrhages, there are multiple hemorrhages on the posterior pole. All types of hemorrhages you can see, M-shaped hemorrhages as well as dot and blot hemorrhages all over the scene picture, that is on the posterior pole. Apart from that, the macula is showing the hard exudate with little bit grayish look, or there is absence of the foveal reflex suggestive of the macular edema. So this right eye is most likely a severe NPDR case, or on this photograph. But if it is detailed, then considering the hemorrhages and suballoid hemorrhages, this will go into the proliferative diabetic retinopathy PDR case. Same thing about the left eye. Left eye is having clear media, that's why you are getting the good picture. The disc is pale and will covered with the fibrovascular proliferation or glial tissues, and there are glial membranes all over the retina, mostly on the posterior pole, more on the superior aspect of the arcade. And inferiorly, you can see there is a sclerosed vessels, arteriosclerosis there. There is no blood flowing through the inferior arterioles, and there are dot and blot hemorrhages as well as superficial hemorrhages. So this is a clear-cut case of proliferative diabetic retinopathy or advanced diabetic eye disease with some peripapillary tractional detachment is also there, and focal TRDs in the superior arcade with kinking and distorted blood vessels, which also shows that there is a tractional detachment.
Thank you, sir. Dr. Vignesh, sir, could you share some, clinical trial resources which postgraduates can use? Even nowadays, examiners like to ask about clinical trials in retinal diseases.
Yes. So actually, so PGs have to know the older studies which are like DRS and ETDRS very thoroughly, because these are still very relevant and very important. And coming to the present day scenario, the DRCR clinical network, that is the protocols, various protocol I, protocol S, protocol B. So these are very important studies, landmark studies in the treatment of diabetic macular edema as well as diabetic retinopathy. So these are where we have to see usage of intravitreal steroids, comparison of anti-VEGFs, comparison the PRP laser. So everything, these are the protocols of DRCR network. I want every PG to know about it, because these are exam questions. Also what we are going to have, the conclusion of the protocols, what were studied, what was the design, and these are very important, especially for because diabetic retinopathy is the commonest clinical case, their fundus case they are going to get. So every PG has to know in and out of diabetic retinopathy, grading, treatment part. So the treatment part, we can know from this protocols designed by the DRCR.net. So they have to be thorough with all the protocols.
So just I kept another picture to highlight extent of retinal ischemia, which is seen on the left side with extensive cotton wool spots. And here, more of inflammatory pathology on the right side with a succinate ring of hard exudates. So highlighting the inflammatory pathology, inflammatory cause of macular edema in these cases, and more of ischemia, which is seen on the left side. So would the approach to the case, how would it change? Manoj sir, maybe you can guide us.
Yes, the left side picture is more of a mixed type of retinopathy. Diabetic as well as hypertensive retinopathy. You can see the features of both one. So first of all, approach should be as a standard thumb rule for the PGs or for any treating surgeon. The systemic control is the rule. As far as told last case that hypertension was controlled and everything subsides. Same thing happens. You get most of the time achieve the maximum results by systemic controls. Apart from that, if you do the local investigations for ocular investigations, you will come to know that what is the exact state of the disease by doing the OCT and angiography. Extent of the ischemia, and if macula is ischemic, then the prognosis changes and approach to the treatment also changes. Accordingly, we will decide once we are in hand the OCT and angiography. Then the line of treatment, local line of or ocular management varies. Apart from that, systemic management plays a major role at the first line of management because it doesn't look very severe case or any emergency to treat the ocular. First, you have to control the systemic things. Basically, these are the microinfarcts, and again, we know that these things are the warning signs for the systemic irregularities, and they warrant the first line of treatments.
Just Dr. Rohit, would you like to add any final points?
I believe our two senior panelists have already covered all the points, and it was a great learning session. There were a lot of key points which were discussed, and I really learned a lot when Vignesh sir spoke about the role of steroids for diabetic macular edema and in which systemic conditions we need to avoid anti-VEGF and go for steroids.
Great. So this was a very informative session which we had. Dr. Santosh, sir, could you give us some closing remarks?
Yeah. So, Ashish.
Yeah.
Thank you so much, Dr. Ashish, Dr. Rohit, Manoj sir, Vignesh sir, and we have Dr. Rakesh sir with us. He is Professor HOD from Thane RGMC. Sir is always keen on this all PG program. Sir, would you like to say something, suggest something for this? Sir, you need to unmute yourself. Rakesh sir, you need to unmute.
Yeah, good evening, everyone. Actually, I was coming from somewhere and I was stuck in the traffic and I joined through WebLink. But then after talking to Dr. Sumit, I have joined Zoom because I was listening to whole, proceeding from the beginning. And I would like to thank MOS President, Secretary, and MOS Scientific for doing a wonderful job. And today also it was actually, I have been attending this frequently. And I would like to say that Dr. Sumit Lahane has started this from, I think, when we had COVID. Before that also, and since that he has been actively involved, and every year he has been doing a wonderful job. And today also, and I think I could see in MOS our mentors and our moderators, and they did a wonderful job. And I would say that presentation was also good. And the discussion was, I think, very good. And Dr. Ahuja has also conducted it very well. So I would like to congratulate MOS, and I hope that this is continued. And MOS is doing a wonderful job. I think we have to congratulate and we have to appreciate what these people have been doing. Even last year, MOS had done. Even this committee is doing a wonderful job. Dr. Santosh Agrawal and Dr. Atul, they are doing a wonderful job. Every now and then I see, activities going on through MOS, and today's was icing on cake.
Thank you, Dr. Rakesh. Just I want to know what message you want to give to our PGs about
Our
the
PG,
Viva exams, mainly how to go about and how they should be confident enough.
yeah. Actually, now we are actually forgetting about the history part and examination. Today also, MSLAS grid, I think, is the most important part. It will give us a lot of idea about the patient's no complaints also. So MSLAS grid should also be included in all BRVO and all this examination. And more importance of the clinical examination than going for OCT and other things. And yeah, OCT and all are important, but basic clinical examination is also. And I think for PG is important is to know about that case. We know many things about the case as such, but what should be done for that patient is the most important thing. Because when we ask students, they say that this can be done, this should be done. No, what is to be done for this patient? I think our examiners were also asking them what should be done for this case, and how will you say that how to manage this case is the most important, looking at the other features like a patient has other systemic complaints and how to go about it. I think that is the most important thing, and with confidence they have to present. Today also, when they will present more and more cases, they will get more and more confidence, and they have to keep in mind that for that case, it is important how to manage that case.
Thank you.
Thank you, Dr. Rakesh.
Yes, sir. Thank you, sir.
Actually, it's a wonderful discussion. There was very learning tips from each panelist and each case.
Yes, sir.
And thank you all panelists and all experts for sharing their valuable time. Actually, just I want to share a few messages for our PGs that one thing is they should attend these webinars because you come to know what type of questions are asked and the very basic and micro details of our cases. And second thing, the whatever you read, na, just don't mug up all the things. Certain things are you have to remember, but certain things you should ask yourself why this happened, how it happens. If you are not convinced with that answer, then you ask your mentors, your professor, lecturers, or your seniors. But that is very important. Basic, you should learn from heart. So this is a very important message I want to convey to you, and you should be very confident while presenting the case. You should be like a master of that case. You should consider yourself as a master and present it very confidently. And whatever is asked, first give the common reasons, most probable reasons. Rare things should not be told first. That is also important thing. And if you don't know anything or you are not able to convince, then just tell that, sir, I am not able to answer this question. So they can ask another question. Okay. So these are the certain tips I want to convey to you. You have presented very well. I am very happy that our PGs are to the mark and they will do best in their exams. All the best to all the PGs. And thank you all mentors and our expert panel for enlightening us. Thank you from my side. Now over to Dr. Mandar also is there. I want to know his comments as well.
Yes, good evening to all. It was as usual excellent PG webinar, and congratulations to Dr. Sumit for conducting this beautiful PG webinar. I think this is a very important activity, but I think the postgraduates are very fortunate that they are getting a platform to present cases in front of experts and learn the nuances. So it is both ways. It is also as a student you learn, and also you learn as an examiner what kind of questions will be asked. So you can prepare your case accordingly. And I think it's an algorithmic approach which you have to develop, because there is a system in which you follow. So I think you got some very important tips from our panel of experts. And I wish all the postgraduates the very best for their future course and for their upcoming examinations. Thank you.
Yeah, over to Sumit, please.
Sir, I would like to thank everyone. Thank you, Entod. Thank you, MS, and all the faculty for being here. And we call it a night.
Thank you.
Yes.
Yeah, thank you everyone. Dr. Vignesh, Manoj,
Thank you.
Ashish,
Thank you.
Deeplata, Aishi, and my MOS team, Atul and Mandar.
Thank you.
And
Thank you
Vardhaman,
very
he is not there, but I thank him also. Thank you very much.
Thank you. Thank you all. Good night, sir.
Good night. Good night. Good night.